Thank you guys for having me. My name's Edgar. I'm a podiatrist in Miami, Florida, working with Barry University. Thank you so much for Barry Without Borders for having me. I'm here to talk a little bit about surgical treatment options for diabetic foot ulcers. It's funny because usually, even with my students, the surgery part for diabetic ulcers is actually the easier part. It's kind of like, I don't know if anyone's watched the show Game of Thrones. It's a long buildup, and there's a lot to kind of consider before you could take it to surgery. Funny enough. But so the surgery part is actually the easier part. It's just kind of the whole workup is very comprehensive. Let me go ahead and uh, oops. Let me do this. Cool. So, epidemiology about diabetic foot ulcers, right? It's increasing globally, and I think this is where podiatrists and everybody in healthcare, right? It's a team effort that's making sure that that limb salvage is the goal, right? In a little bit, we'll talk about the consequences of just go ahead and proceeding with below knee amputation and how the life expectancy goes down and how much metabolic power is needed with the body to just overall compensate for the amputation, right? So over 537 million adults. I have it right here in 2021, and it's just continuing to grow. 6% annually will develop eventually a foot ulcer when they have diabetes, and up to 25% will need amputation, which is kind of scary, right? One out of four people will essentially need an amputation of some level, which is kind of alarming. And the cost, right, in medicine, especially for the students who are getting into residency and becoming and cost containment in medicine is extremely gaining popularity, just trying to have costs, and diabetes in general is a 9 to 13 billion dollar kind of cost um, to the healthcare providers. So 1 out of 3 U.S. citizen in 20, I thought this was kind of interesting. 1 out of 3 people will have diabetes by 2050 if this current trend continues, right? So we definitely need to do our part in educating patients and being able to work them up appropriately, right? So pathophysiology about a diabetic foot ulcer. 35% of the times they're neuropathy, and I'll talk what that means in a second. It's essentially the body's inability to feel. You have like autonomic, you have sensory, you have all these different types, but um, essentially the not being able to feel and causing a epidermal breakdown, eventually a full thickness ulcer, causing a wound. Ischemia, right? So I live in Florida, Miami. So I always tell my patients it's kind of like a hot summer day in your front lawn, and if you can't have water hose to a grass, what happens to the grass? Eventually turns yellow, brown, and eventually dies. Ischemia is the same way. So essentially, this skin just does not have the oxygen and the nutrients essentially to perfuse, and causing a skin breakdown, just having it sensible there. And an immune dysfunction, right? So instead of water in your bloodstream, diabetes, hyperglycemia, another fancier name for it, is essentially having Coca-Cola or Gatorade in your bloodstream, right? So it causes a lot of dysfunction in your entirety of your body,
Liam, go
right?
to the top, put that picture down.
Okay, I'll put that picture down. Sorry about that. Um, Leading to chronic wounds that fail to heal. So we'll talk about neuropathy right now. Um, so neuropathy, in a histological point is axial damage, right? And demyelination, right? So nowadays, with people that are in early stage peripheral neuropathy and a conservative management, funny enough, there's been emerging literature as it pertains to vitamin B and it kind of is allowing that WD-40 to a bicycle or a car, essentially. So that it kind of eliminates this demyelination of the nerve, and it kind of allows them to kind of like improve and their frequency and their intensity of that neuropathy feeling. So the vitamin B supplementation, by 3 months, they are seeing some promising results, but typically it has to be an early stage type of patient. As it pertains to this, right? As it continues to demyelinate and you continue to get damage, you get loss of pain, loss of temperature, proprioception. I had a patient in residency, they burned a patient burned the bottom of their foot, and they didn't realize they were in the beach with their family, and they didn't realize until they looked down and there was blood everywhere, and they just had no sensation, and they can't feel anything, and they developed a full thickness wound, right? So making sure that we kind of do a good Sims-Weinstein exam that we'll talk about in a second is very imperative. And then there's motor, right? So we talked a little bit about the sensory, and there's motor. So some of these um, nerves will essentially cause atrophy to certain parts of your foot muscle, causing the bony prominence to the bottom part of your foot. And why is that scary? Because once those muscles and that fat eventually dissipate, it will kind of cause a skin breakdown much easier because you have that bone to floor contact, and it just doesn't really allow you to distribute the ground reactive forces there, right? So this is kind of the thought process that kind of goes in, right? You start with foot atrophy, you get a foot deformity that causes abnormal distribution. Eventually will cause an ulceration, infection, and eventually if that infection goes into bone, you're looking at amputation, right? So if we could kind of stop it essentially right here with good footwear and just kind of overall every 3 months checking him out, doing a Sims Weinstein, it'll be imperative, right? So there was an article, famous article, just for completeness sake, is Lavery, right? If you have a positive probe to bone, you have a 87% sensitivity and 91% specificity, right? So this is a picture of the ED. This went full and full, so I think this is the 110%. If this was my article, right? So and as it pertains to just not only in a physical exam, right? When you're doing the vitals and labs, that same author, Lavery, kind of mentioned an ESR above 60 and a CRP above 7.9 is essentially what you're looking at, right? And then of course you're looking at WBC, your white blood cell count, left shift of your neutrophils and everything along those lines. But these are advanced markers that you can kind of look for to kind of determine if there's infection, right? And that kind of predicates if you need to do some sort of incision and drainage or surgical management for your diabetic foot ulcer. So why is this important? Loss of limb, right? And you want to prevent the fact of amputation. And the earlier you could identify and educate the patient, the better that you have a chance of preventing an amputation, right? So this picture here, from here to here, is in a span of just weeks, right? And with improper education and offloading and shoe wear and education, they're just going to continue to walk, and the wound gets bigger and higher risk of amputation, right? So that's a little about neuropathy. What about ischemia, right? So kind of like I mentioned before, it's kind of like that no water to a grass. If you look at the um, angiogram here to the left, you can see that anterior tibial artery is occluded right here. And after some revascularization with our colleagues, with the interventional radiologist, they were able to get that kind of going. And I want you to appreciate too, once this anterior tibial artery is restored, you really get to see a lot better distribution from these tributaries of this artery, right? So diabetes accelerates atherosclerosis. Narrow blood flow, you have plaque, it reduces the blood flow to that area, essentially impairing wound healing and oxygen delivery, right? So, and then immune dysfunction, kind of like I said, right? So this is the fancy words: impaired neutrophil function, cytokine response, delayed macrophage. I know there's some of the students who are brilliant. At least if I was there, I'd be like, what the heck is a neutrophil? So neutrophil, as you guys know, first line of defense when it comes to wound healing, right? So it engulfs the bacteria. So if you don't have that, the bacteria kind of stays and kind of keeps that infection rate high. Cytokines initiates the inflammatory response. So what do we do when we see a wound care? We're going to talk about in a second. You have to debride the wound with either a gauze, curette, 15 blade to initiate a inflammatory response. So if you don't have these cytokines to even allow you to promote an inflammatory phase, you're looking at ineffective signaling causing delayed healing. And then macrophage has multiple for any histologist in the room, I know I'm not doing it justice, but essentially promotes the angiogenesis and tissue repair, right? So if you don't have that, then you're not really getting any tissue. It's that area, right? So some risk factors, right? Patients, you have patient-specific factors. You have the vascular, neurovascular that we kind of alluded to earlier, and then the mechanical and behavior of the patient himself, him or herself, right? So typically, high-risk patients, anybody diabetic for over 10 years, they can be controlled with an A1C of about 6.2, but as the duration continues to go on, even though they're controlled, it is something that they can have an increased risk just secondary to the duration of having the diabetes, right? So, and if you combine that with a poor glycemic control, I know I put 7.5. I'm a little bit more loose. I understand that 6.4 is essentially the threshold. Anything above 7, I really start having a serious discussion with them. Anything above 7.58, I kind of reluct to do any surgery, especially if it's an elective type of surgery, right? And with this poor glycemic control, also have neuropathy and peripheral arterial disease as well, right? And obesity is actually one of the biggest factors for failure. There was To go off topic, we did a literature on obesity with total ankle replacement implants, and we found that obesity was just that high of risk factor for failure as much as diabetes. So it just overall causes metabolic syndrome, hyperlipidemia, hypertension, all these other conjoined comorbidities. So it's something that kind of you want to err towards as well. And history of amputation. So we kind of talked about this. You want to do your peripheral neuropathy. Dr. Hill does a great job with the university educating the podiatry students. But the sensory, the motor, you get your Sims Weinstein, you do your all 10 points at the bottom of your foot, seeing if it's in a glove and stocking distribution, meaning that if it's starting with the toes and eventually works its way down the heel. As you guys know, the nerves are biggest on your back, right? And as it continues to go to your extremities, whether it's your fingers or your hands, and vasculature is the same way, the nerves just get smaller. So these nerves, usually on the toes and the hands, on the digits particularly, will get affected first and then eventually work its way proximal as the nerve gets a little bit bigger. And then you want to do your ABIs, your peripheral arterial disease. We have this available in the university clinics. In my hands, I have a pretty low threshold to pull the trigger and get a internal radiologist or a vascular um, specialty. I just feel like it spreads the risk profile, number one. I don't know if it's because I'm a young attending, but that's always kind of good. You get documentation from another physician. And overall, I just feel more comfortable in the capacity of a specialist more so than me, right? So I kind of just allow that, but we do have that availability to do the cuff with the ABI. Anything below 0.9 is essentially something you want to worry about, right? So, and then any autonomic neuropathy, right? These impaired sweat glands causing cracking of the skin. This is the picture of my foot. No, I'm just kidding. That's not my foot, but it causes cracking, right? And these fissures that you see here, the center aspect of the foot, will kind of predispose you to infection. So you want to make sure you be aware of that, right? And lastly, mechanical behavior. So ill-fitting shoe wear, right? I think that's very popular. A lot of people like to be barefoot or just wear their chancletas. I tell the word that I always say is be intentional with your shoe wear. Something soft, very hard, something that allows you to get you more support, right? This is the distribution demonstrating where the high area of pressure points are. And typically you want to look out for sub first metatarsal, sub fifth metatarsal, and the heel. You will, because of toe off in your gait, you will see some as well with the big toe. But typically the underneath the big toe, the pinky toe, the metatarsal, and the heel are going to be the most high risk. So if you are going to do any offloading pad or orthotic modification, just things to kind of consider for your patients, right? So type of diabetic foot ulcers, I do think it's imperative because, again, understanding the type of foot ulcers, you don't want to be doing these big reconstructive foot surgeries to prevent these diabetic foot ulcers on a ischemic wound because everything you'll do will fail, right? Versus a neuropathic ulcer. So I do think
Now,
understanding the
I do an
etiology and um, the background of these ulcer types is very imperative. So neuropathic ulcer, right? You lose your protective sensation. They just walk on it. Essentially, it will, because of the abrasion and the repetitive um, force to the foot, essentially the mechanical forces will outweigh the resistance of the skin. So it'll cause the skin breakdown, causing a wound. So ischemic ulcers is a vascular compromise, right? So this is a patient when I was a resident, and it was right when COVID started. So I was first year resident when I was COVID started. So it was kind of scary. And he said this started like a week ago. So this looks like a scene from Mr. Deeds where his foot turned black. So poor blood flow, kind of like that grass analogy, right? If you don't water your grass, it turns yellow, eventually brown, and eventually dies, right? So and these are the patients that have poor healing capacity. So even if you want to do a reconstructive or an amputation, right, they are high risk because the one thing you don't want to do is amputate at the big toe. And if they have peripheral vascular disease at the level of the midfoot, and you just take the toe and and there's no blood flow to this area, this incision and this amputation will fail, right? This is something that will require a staged procedure, right? You want to eliminate the toe, excise it, amputate it, and stage it where you open it, you eradicate the infection. That way, the soft tissue can demarcate and um, you can eradicate the infection. And then from there, you could plan how far back do you need to go, or go ahead and doing a transmetatarsal amputation that we'll talk about in a second. And then you have a combination neuroischemic, right? Those ones are kind of you're looking at Mount Everest when it comes to that, right? Because you have not only a bad blood flow, you have um, they have no feeling, right? So I present a case, as we go on now, right? That's a little bit of the background of diabetic foot ulcers. This patient comes in, you have a full thickness wound, you can kind of see it extending underneath the second, third digit, right? Positive probe to bone, MRI comes back as osteomyelitis bone infection, right? So what do you do? Do you do long-term IV or oral 6 weeks antibiotics, or do you go ahead and proceed with an amputation to kind of just ensure that the infection doesn't continue to spread proximally, right? So surgical options when it comes to you when you have these types of wounds. You have sharp or essentially surgical debridement, which is the gold standard. You want to take out that bacterial biofilm and make it bleed to cause an inflammatory response. That way, the body recognizes a wound there and can kind of send these chemical mediators to there to allow it to heal, right? And when it pertains to sharp debridement, it can be as gentle as a 4x4 gauze. Funny enough, because if they're very hypersensitive, especially those patients with an ischemic wound, you'd be surprised that gauze can be very abrasive. That's why for my elective cases, I never use Kerlix. I think it's the devil. I think it's a very abrasive type of dressing. The only time I use it is over cast padding if I need to do some level of compression maintenance to that area. So it could be a curette, it could be a 15 blade, 10 blade, or scissors as well. So a variety of ways you could do these. And there are a few type of creams, right? There's only one in the market. I'm not trying to promote any names, but there is one that's a collagenase and essentially does the debridement for you. The only con of doing this collagenase type of ointment is it requires a daily dressing change, right? And I've spread the limit and stretched the limit, excuse me, to it and done 24, but I will not exceed 72. I do see harm in that, but I do up to 24 and 48 hours is typically what I do. So you can apply that as a dressing as well. So, right. So this is the triad, I'd say, right? You sharp the breed, you do your wound care, you put your dressing, whether it's that collagenase I talked about earlier, or if it's wet, you want to put either betadine, hydroferro blue. If it's dry, you want to moisturize it, right? And offload. Right. So if you do sharp debridement, you do the wound care, you offload, essentially in 6 weeks, you want to see a 40 to 50% improvement. If not, you have to either change it or there's a factor that's not working in your favor that's not really um, been discussed, right? Whether it's the blood flow, the neuropathy, the shoe wear, it could be something else, right? It could be PG. So it could be a variety of different, or it could be cancer, right? And you have to do a biopsy. But typically, our standard is you want at least 50% decrease in wound dimension size in about 6 weeks, right? And if I got like 30 and it's just taking a while, I'll still accept it. But I know there's articles saying that it should be 50. So back to that point, right? So you don't need to always curette it, right? This is one where I feel like the value of a curette. I work with students and sometimes teaching them. They'll be here for an hour, and I think they would like that, just because they get an instrument in their hand. But just getting these, these are tenotomy scissors. You can use Metson bomb. So essentially, just using a pickup on the left hand and excising this non-viable fibrotic fluffy tissue, right? This is essentially honey to a bee, meaning that bacteria love this stuff. They will feed it, so it is prone to infection, right? You don't want to go too deep either. You want to be able to differentiate and kind of just see how far it goes back, right? So you kind of get a superficial layer. You take that and then you excise it, you put it in your coffee, right? Or you put it to somebody I'm just kidding, you don't do that, but um, so you put that away and then you go ahead and now you could feel free to continue using your scissor, or go ahead and proceed with a curette and a blade at this point, right? And the goal is if this is an initial visit, you want to see how far it goes back, right? Kind of like I alluded to earlier. Do you have the protective sensation? Does it positive probe to bone? We understand that if it positive probe to bone, the high chances of osteomyelitis, right? Do you get an MRI, advanced imaging, blood work, admission to the hospital, and things like that? So those are the kind of conversations that you have to discuss with your patient, right? So taking these Metzenbaum scissors layer by layer, feeling it, you know what I mean? And you can feel the second metatarsal. You can get your cotton tip applicator for measurements for the depth, as well as just seeing if it is positive probe to bone. But just wanted to give you another thought on debridement, right? So obviously you debride out the callus as well. You'd want to pack this wound and do a formal workup, right? But the fact that, turning a chronic wound into an acute wound, right? So the picture on the left here, you see a sub first metatarsal ulcer, right? And it can be for a variety of reasons, but essentially this is a mechanical reason because the first metatarsal is plantar flexed, causing repetitive motion pressure to that foot, and it just causes a skin breakdown, right? So we debrided it, we offloaded it with certain particular type of shoes and felt pad, and just in 2 weeks, sorry, and you can kind of look away if you don't like stuff like this. Oh, 2 weeks it went away. I think it kind of went out of order. I apologize, but in 2 weeks it went away. But in case you have a weak stomach, I don't know the audience and the crowd. This is a time to turn away and just maybe listen to my voice or not listen to my voice. So I had a patient in the ER. I want you to look at the bottom part of the foot, right? So this is something not only for the students, but for everybody. Essentially, if you look down here, I want you to appreciate this radiolucency that is
Yes.
bubble like. And I want you to look at the clinical picture here, right? So it's correlating with the x-ray. So you cannot miss this. This is gas gangrene, soft tissue emphysema. Okay, so you make your incision and drainage in the ER, right? And right away underneath the skin, it just looks not good. It's not viable. You can see the needle driver, the hemostat there. It's tunneling underneath, going all the way to the fifth metatarsal. So you can tell the level of abscess has been affected there. And to make things worse, on the dorsal aspect, it also been affected, right? So you make your incision there, and I want you to appreciate the bubbles there, right? We're always taught crackling, and when you're palpating it you feel this fluctuance, and when you make your incision and you open it and then you express that fluid out, you actually see the bubbles and actually the cracking. And then if you're the provider there, the whiff of that odor will hit your nose, and it's a smell that you'll never forget. It's like the first time you smell new car smell or new shoe smell. I don't know, those are my favorites, but in a bad way this time, because this is like the worst smell you'll ever smell. You have to ensure that it communicate, you have to get it all the way, right? So there is a gnarly picture where you could see it communicating from the top part of the foot to the bottom part of the foot, right? So this obviously requires an emergent uh, surgery, right? So we followed where the abscess is, and this is the bottom of this patient's foot, right? And he's just on his phone chilling, probably scrolling on Instagram, and we're here kind of freaking out. This is called packing strip iodoform. So anytime you open a wound and um you have areas of just open pockets, you want to pack it, because that pockets, it's kind of like me at a party, right? There's too many people at one room. I kind of want to go away to people and stay at a part of a room where I'm quiet. Bacteria does the same thing. So if there's like an area where they could go in and migrate to and hang out, and they go to that area, right? So that's why you mitigate that by putting these iodoform packing strips, sometimes soaked with betadine, so it prevents abscess formation to that area. This was the top part of the foot. You can see we held it with retention sutures here, and we packed it. Okay, so eventually, after multiple series of debridement, we put on this graft. The graft is also kind of necrosing, so right away, kind of like to piggyback of what I mentioned earlier, making ensuring that this ischemic component is not affecting our wound capabilities, right? So he had frequent visits with his interventional radiologist as well. So we did a wound. At least the skin is being epithelialized, meaning that there's granular tissue and the depth has been increasing significantly, right? So we went back in, we did a repeat debridement. As you can see, the dimensions are getting smaller. The granulation tissue just looks much better. We ended up putting another graft on there and essentially successfully being able to heal, right? It was a 4 to 6 month process, if I'm not mistaken, but overall he was able to heal. This is the top part of the foot, same thing. We did put a negative pressure vacuum device to that area. This is kind of going backwards, but you see the graft here, and you can see the graft eventually taking, and some of it kind of just taking its time. Overall, kind of the same progress in the bottom part of the foot, and eventually was able to heal, right? So the imperativeness of kind of what I mentioned, the debridement, the offloading, the and the wound care does wonders, but patient education, and I do think patient mental health is very important. If they don't want to get better, you can tell them to do everything. You can lead a horse to water, but you can't force them to drink it kind of mentality. So I do think this patient did require a lot of time, a lot of guidance, a lot of mental care as well. So, but eventually was able to heal, right? So going from this to this to this to this is essentially what we all should take pride in, right? Essentially preventing, because if you had that, if a lot of other specialties, when they get that gas gangrene, they immediately go amputation, below knee, right? So understanding and this was the picture of the offloading just after 2 weeks. There is something that you can do called a Achilles tendon lengthening, and you could adjunct it with a total contact cast, right? And I want you guys really quick to appreciate these lines here. They're going to be a triple hemisection, kind of also known as an accordion, how you lengthen it. But they found that if you do lengthen your Achilles tendon, they found decrease in forefoot pressure because you just have more range of motion, right? So you it's very easy, it's usually done adjunctively. You can't do it as a primary, just solo kind of procedure. But you go in with your 15 blade, 50% of the Achilles, and then you typically dorsiflex the foot to get the tension, and then you hear the crack, and then you release 50%. You go approximately 2 to 3 centimeters proximal to that first one, and then you go ahead and you release some of that as well, and then you release 50% as well. So that is why they call it the accordion, right? And based off that, you could decrease the forefoot pressure because you're going to have much more range of motion. I would say be careful though, right? Because you can, as you see this video here, rupture the Achilles, right? So as you can see here, they kind of went overzealous, and you see a complete rupture here, right? So it's very imperative that you stay at that 50%, because if you cut the Achilles, you could develop a heel ulcer because you get something called the calcaneal gate, right? So you want to just be imperative, be cognizant, and be very intentional with your blade incision, right? Save a limb, save a life, right? Saving the foot is the highest priority, and partial foot amputation is better than the whole foot, right? Because if you save the foot, you have highest ambulation. If you just do the toe, you have high likelihood of still ambulating, but without it, you cannot ambulate, right? So if you amputate above the knee, I want you to appreciate the left, right? When you have normal gait, the energy expenditure after expenditure, I'm English was my second language, I apologize, but after amputation, if you notice, normal gait is at 100%, right? If you get a foot amputation, it's 110. But look at the very right, 160% more, 60% more energy in the body. So let's say this patient has cardiac issues, kidney issues, obese, right? And this is kind of the reasons why the life expectancy goes down, right? So at year 7, 65% will life morbidity, unfortunately, right? So even though year 1 you can get at 20%, but if that was my sister or my mom, or a family member, and you're telling me that you do a baloney amputation, 65% you're going to pass away, it really does kind of put things in a different perspective. So trying to limb salvage is extremely important, right? So a little bit about the surgical reconstruction, right? So you have the osseous reconstructive, whether you kind of just shave off the bone spur, which is an exostectomy. You could do osteotomies to kind of mitigate and alleviate some of that plantar pressure that's causing the ulcers. And you could do that with osteotomy, or you could actually fuse a joint or do a functional amputation, like taking off part of the metatarsal head, if that's the part that's causing you a wound, just to like eliminate and prevent any infection, right? And you want to respect the soft tissues. If you amputate, you can't cause deformities if not careful, that we'll talk about, right? So goal of an osseous reconstructive, plan a great foot, right? You want to make sure there's no pressure points, being able to wear a shoe or a brace, and just making sure that you prevent reoccurrence and ulcerations, right? So this is one called the Charcot foot. If you look at the x-ray on the left and the right, I want you pay your attention to the midfoot right here, right? If you kind of notice, it's kind of not really, it's kind of just liquefied. Charcot is a consequence of diabetes, and I always compare it to Oreo cookies, right? I might be skinny, but I love to eat. I'm a professional Oreo cookie twister, funny enough. And so what happens if you leave an Oreo, and you have to eat Oreos with milk, right? Or else you're just you're crazy if you don't eat Oreos with milk. So what do? Let's say you put an Oreo cookie in a glass of milk and you leave it there for about 30 seconds. And then you take the Oreo cookie out. You put it on a piece of napkin. What do you really appreciate with the Oreo cookie? It's mush, right? It's because it's been in the water. It's been in the milk for so long. That's what Charcot is. Again, it's a consequence typically seen with diabetes, but there's a various etiologies of it. What it is, there's two theories that the nervous system allows the arteries to open up and it causes a washout of the blood. And it's kind of like my Oreo cookie analogy because the arteries open up so much that your bones, the Oreo cookie, is just in this blood flow. And that's the acute phase. A lot of providers and healthcare professionals typically diagnose that as cellulitis, right? Which I get. Hot, swollen foot. Oh, you probably have cellulitis. Here's Keflex, here's 10 days BID, antibiotics, you're good to go. But they missed a Charcot. Now, let's say you have that wet Oreo cookie and you kind of just carry it in your lunch bag. It disintegrates, right? So that's why it's so imperative to diagnose the Charcot before it causes a breakdown, because then it could cause ulcers, right? So this patient had an ulcer in the midfoot, and you can kind of see the midfoot. The bone right here, the navicular is subluxed, right? So this is when you could do a reconstructive, put the bones back, and then kind of to a pertinent place, plates and screws. In this case, we did these big screws to kind of put it in place. We kept them non-weight bearing for 6 weeks, allowing it to heal, right? So in foot and ankle surgery, at least, is the quickest growing special surgical specialty um, in the internationally. So this is one where you have to make a huge incision. Now there's minimal invasive techniques, but I want you to appreciate how many joints the surgeon has to repair, right? Again, you have to put that foot in a plantigrade position, right? So you have to take off the cream of an Oreo cookie, put it in a proper alignment, right? And again, as I alluded to earlier, foot and ankle medicine is the fastest growing run, right? Nowadays, there's all these companies are investing in foot and ankle because they want to develop these jigs, targeting guides to do that surgery that I just showed you earlier, right? So this is one that they're preparing the bottom of the big toe part of the foot, the midfoot, and they're making sure everything is rectus, and they're going to throw a big screw in there, right? But this is a new device. I don't use it. I just kind of freehand it. But this, again, this is the modern day of foot and ankle surgery where, they're going to utilize a plate here, but along the plate you could attach a targeting guide so it's kind of foolproof, quote unquote, right? So this is one where you are drilling into the foot and to put being able allowed to throw the screw, you measure, right? And this is then countersinking, and then they're going to insert their huge screw to that area, right? So and that's kind of how you maintain a plantigrade foot there. Okay, then what they're going to do is they're going to go ahead and put the screws into the plate. But again, you can kind of just appreciate how extensive some of these reconstructive surgeries are. But at the end of the day, you have to ensure that if this is going to allow them to keep their limb, it's something that you need to do. As well as what we talked about in the beginning of this presentation, right? You want to make sure they're cleared in a vascular setting. You want to make sure the skin integrity is okay. And you want to just ensure that you are choosing the right procedure for the correct patient. Okay. So for osteomyelitis, it's two options, right? IV or oral antibiotics. There's been more emerging literature with oral antibiotics being comparative and having a similar success rate, but there's no long term as compared to IV having a PICC line, or bone resection, amputation, right? So those are kind of what you're looking for. And what do I kind of consider? Is there any acute infection? I get my imaging, vascular status, and healing capacity, right? So you got to see if there's any sepsis, do your labs, vitals. If there is, you got to do an emergent IND with cultures and multiple debridements, right? Get your X-ray, get your CT, get your MRI, assess the extent of the disease tissue and the bone. Again, you want to respect the soft tissue. And the reason why I get the imaging and why I think it's imperative to get advanced imaging is essentially to ensure that you're excising all margins, the devitalized and the tissue and the bone, right? The last thing you want to do is just not resect enough and you still have residual bone infection to that area. So vascular status, we kind of talked about this, right? PVD, you just want to make sure you do your testing. A healing capacity. Um, I think nutrient, right? There's even nowadays, there's a lot more industry that are getting into supplementation just for overall optimization metabolically, meaning, getting your vitamin D, getting all your zinc, your everything along those lines. So these are kind of your markers, your protein levels, your albumin, your pre-albumin is very important. Um, just to kind of understand the nutritional status of the patient, right? Amputation goal is to make sure that if you can have preserve as much of the limb as possible when it pertains to the length and ensure that you do a amputation where they're not prone to any ulcerations, right? So remove any abscess, remove any non-viable bone, maintain a functional stump, and again, respect the soft tissue and balance the foot, right? So when it comes to wound closures, and we're going to talk a little bit about amputation and then finish up here, it's a very imperative, right? To me, the skin is so imperative, especially in an area that's devascularized, right? You last thing you want is to kind of get a pickup and really pinch on that skin, um, causing that breakdown of that microangiopathy kind of level. So making sure there's no tension, right? End-to-end approximation. My favorite way of closure construct is a staple suture combination, and I conjunct it with this proprietary device that decreases the skin tension here because it allows you to put the skin closer together, and you put this through this loop here through the suture. So that's kind of my preference, right? You want to make sure the sutures are not too tight. You want to make sure the sutures are as small as possible and as it pertains to size. That way, it kind of just decreases the overall pressure to that skin. Okay. And when in doubt, when you think there's any leftover infection, keep it open. The last thing you want to do is close an abscess and it blows up, and then you got to take more and take the patient into more anesthesia, 30-day readmission, dings the hospital, dings you, leave it open. There's nothing wrong with doing stage procedures. Okay. So there's another way for a TMA. This is kind of like a baseball stitch. Essentially, it kind of, again, anything we could do to kind of offload, excuse me, particularly the incision site. We started off with some vertical incisions and then did this, but I want you to appreciate how there's not a lot of tension on the skin. The second thing I want you to appreciate is the plantar skin, you always want to flap up, right? The bottom part of your foot has just more meat, has more blood flow, has more fat, has more arteries, right? So you always want to do what you can. And this is why it's kind of difficult. It is kind of like plastic surgeries. You want to make sure that the plantar skin, you have enough to flap up. And this is called a drain. And essentially, it's just to prevent any hematomas, just to prevent any bleeding to that area, right? So these are your levels: toes, level at the MPJ, which is a little bit more rare. Transmetatarsal, you have your Lisfranc, your show parts, and then your signs is your ankle, right? So you have your hallux. You typically do a racket incision, and the reason why, if you look at the lateral view, it looks like a tennis racket, or if you live in a sunny area like Miami, a pickleball racket, I guess. And that's kind of like what you're doing, right? You're doing a two diverging semi-elliptical incision, right? So if you have a squeamish stomach, please look away. Um, I should have probably had this slide every slide, but anyways, so this is one I found. I kind of disagree with the medial side incision. I like to elongate it, but at the same time, I see this is probably a stage procedure, but your first index procedure should always be planned for your second, right? So this is one, this patient came in with dry gangrene, right? So you want to go ahead and you have to excise it right away because again, it's an area where a lot of bacteria would like to feast. So you got to eradicate that part and then deal with the soft tissue afterwards, right? So you can see the extensor tendons, and that's your metatarsal there. I finish it off with a blade, but there's nothing wrong with using a Metzabom scissor along those lines, right? You kind of free up the bone. You do not want to have the bone just completely sticking out, even if you're going to go back in 24 to 72 hours, right? You can do a bone cutter. I use a saw. and you kind of just want to like cut that part out. That way you have some soft tissue covering the bone. Obviously, you're going to put a dressing on there, right? The one thing I will say is you took out the cartilage, right? The cartilage has a cap, and the bone is like a sponge. Because imagine putting a sponge in a bucket of water, right? So it'll absorb. But I want you to appreciate this cap here, right? So it kind of prevents access to a barrier for the infection. But right when you take it off, as you see here, the inside the bone is very cancellous, as they say. So you just got to be careful of that and be aware of that environment, right? So here's one of a toe. There's a second toe. Looks like this toe has a cap on, and it just does not look good. So you got to amputate that, right? And you can do a partial. In my hands, they just really don't do well. Even if it's just a distal phalanx, I will proceed with the full digit amputation, right? So same thing. You want to do a racket incision. You want to hug the bone there on the plantar aspect because you want to preserve as much skin as possible there, right? So there's an incision. You typically don't use with a tourniquet, so it will bleed. You want to go straight down the bone, right? You're not kind of messing around. Here's when you get to the bottom part, that's where I kind of harp in on residence. You want to make sure you have a good, clean, smooth dissection using the belly of the blade. That way, when it closes, it's atraumatic to the skin. And when you close it, it optimizes and just overall gives you a higher success rate for your skin closure. Right. So the surgery right now, we're just kind of like opening it up. I typically use a towel clip and I kind of just hold that. I feel like I get more better negative pressure to amputate with that versus the pickup that the surgeon has on the left hand. So they're finding the level of the joint here. This surgeon actually opts for a saw. Spoiler alert, which I think is a little bit barbaric. I do think that you can just use your your blade and find the joint. But it is pretty pretty quick as you can see here. But it's a little bit savage, as what the kids would say, in my opinion as well. So there it is. You have appropriate skin closure there. You want to obviously excise any soft tissue, excise your tendons, irrigate copiously, and then go ahead and proceed with your skin closure. Um, Right, and then transmetatarsal amputation. That's yes, you're cutting off half the foot essentially. It seems like an episode of the movie Saw. Keep in mind the parabola, right? It can be performed at any level of the metatarsal. So if you have a wound, that typically predicates how proximal you have to go. This is very important. You want to bevel it. Essentially, you want to go dorsal distal to plantar proximal. Because if you do it any other way, the bottom part of the foot will have a sharp edge. So if you kind of go in that manner, it'll prevent that. The whole balancing the foot, right? You have a tendon here called the tibialis anterior. So I always look at it as riding a horse, right? So if you're riding a horse, you have two ropes, I guess. And if you want to steer the horse to go left, you pull left, right? And the head of the horse goes left, and it'll go that way. And eventually you let go, and then it'll keep the head horse going straight. If you go too far back, this tibialis anterior muscle is one of the most essential, and it causes you to invert the foot. If you cut that, back to the horse analogy, let's say you cut one of the ropes, you cut the right one, the left one keeps pulling, the horse is just going to keep going left. So if you cut the tibialis anterior, you lose inversion, you get a complete everted type of foot. Okay. So the peroneus brevis is the one that kind of does that. At the same time, if you cut the peroneus brevis, you want to make sure that you keep that because then it causes soft tissue imbalance essentially. So something to kind of consider. So here's one, dry gangrene to digits 2, 3, 4. And you kind of have to do this rocket type of incision. You proceed, you take out the bones, you take out the flexors, and I want you to appreciate how the plantar skin you have more so you could flap it up. And that's kind of how you close it, right? So this one, they did retention sutures here, and then they did horizontals here. So the construct, again, I showed you mine with the staples. It's kind of dealer's choice, right? And you want to just make sure these types of patients are already high risk. You want to make sure that there's no necrosis or skin breakdown to this area. Right. So there's a case that I did with my residency director. They had gas gangrene, and this foot here it doesn't even look like a foot. Um, not a lot of skin there, right? And this is the top part of the foot. Look at this toe, right? That doesn't look good either. So we're not looking, it's not looking really good here, right? So we filleted it open. We did a transmetatarsal amputation. We did what we can to kind of save the foot as much as possible. So we kind of had to do some plastic surgery here. We went from that to here, right? This patient eventually got the graft. We took out the sutures. It's granulating it nicely. We did use a negative pressure vacuum device for this, excuse me, as well. And that's kind of how it looks, right? So it does take time. This patient did take almost a year. He was just obese, non-compliant. I think he had 3 cans of Coke every day, which sounds cool, but not good for him. So, and as you continue to go down, it becomes really difficult, right? Because of that whole tibialis anterior and peroneus brevis, right? And you get really muscle imbalance to that. So you want to preserve, if you can, a little bit of that metatarsals. That way you kind of preserve some of the fibers of that muscle. So the foot is plantigrade as possible. So me, I just want limb salvage. I'll deal with the consequences after. But it is something to kind of be cognizant about, right? So again, you have your Lis Frank at the level here, but like I mentioned earlier, if you can preserve some of the metatarsals, you can. I want you to appreciate how the plantar skin is a little bit longer, so you have that flap to flap up, right? So here's one that's just not good and had to be amputated. This is a show part, right? So this is at the level of TN, talonavicular joint, the calcaneocuboid joint, that I had to do, and unfortunately kind of started failing here. And it's hard, right? Because it's just peripheral vascular disease is hard, and you get a lot of deformity, soft tissue as it pertains to that. And usually you want to do in a Achilles tendon lengthening, kind of like I showed earlier, just to kind of prevent any frontal plane movement of that foot. Lastly, right, you have a disarticulation here with the show part. It is what I mean, right? If you do an Achilles tendon lengthening, you could dorsiflex this right here, the foot, and it allows a more plantigrade foot. Eventually, though, if you don't, this will continue to break. And look at it now, right? The calcaneus and the talus is extremely plantar flexed. So we had to go in, we had to break up the bones here, right, and kind of just really open it up, and then we did a nail going up with some screws to kind of hold it. And you can do a frame afterwards to kind of ensure that you have a rectus plantigrade foot. And that's my presentation. Does anyone have any questions or anything? Perfect. All right. Well, thank you guys for having me. I hope that was somewhat informative. Here's my email, Instagram. If you have any questions, please let me know. Again, thank you for having me. It was a really great privilege to speak to all you guys and the screen.
Thank you, Dr. Sai. We appreciate you taking the time to do the presentation this morning. And we had quite a bit of persons on, some of our residents and doctors from Princess Margaret Hospital, our main hospital here, were also on. So thank you so much. We appreciate you.
Of course. No, my pleasure. Hope to see you guys soon in person. And yeah, thank you again for your time. I appreciate it.
Yes, Foot Fest next year. Come on down.
Sounds good. Thank you again
All
so
right.
much, Monique. I appreciate you. Thank you.
All right, no problem. Thank you, everyone, for coming. Thank you so much. We're going to close the room now. I see Dr. Bain is on. Dr. Bain, you wanted to say something?
Hi, good morning, Dr. Mitchell. Thank you so much for the invite to this educational session this morning. It was very thorough. I appreciated the information that was presented. And I think it's going to be very useful. And it's another reminder of the amount of work that we need to do in order to try and prevent our patients from getting to this stage. So it was really motivational to continue on the course of what we do every day. Thank you so much.
Yes, thank you so much. And thank you all for coming. We're going to close the room now. Have a wonderful day. And we have our last day of Foot Fest. So we're going to head out. Thank you so much. Good morning, everyone. Dr. Zonico, nice to see you.